Good morning, everyone. I'm Pao-Ling from National Taiwan University, National Taiwan University, currently in Central Branch as a director. So today is my honor to invite our first section on general surgery. The first speaker, Dr. Yan Chih-Feng. Dr. Yan is from Torng Memorial Hospital. Currently is the vice chair of the department of OBGYN in Torng Memorial Hospital, and also the general secretary of APAGE. Today, Dr. Yan will give us a speech on transvaginal nodes. Let's welcome Dr. Yan.
Thank you, Mr. And good morning, everybody. So this is a general session. Just talking about the transvaginal nodes. So everybody had the workshop yesterday. It's more hands-on. And so this is just an overview about the transvaginal nodes. And so we'll just try to understand where we are and just try to look back and try to look forward. So it's a perspective. So actually, the transvaginal nodes is not totally different things from what we were doing on the gynecology surgery. So just we try to trace back how did it develop, and so what's the current application in the gynecology surgery, and then just try to analyze what's its advantage and disadvantage, and what's its challenge, and what we can do in the future. So if we look back about history, just think about what we are doing from what we have learned from our teachers about this surgery. When I was a resident at around 1990s, as many of you, maybe you haven't, maybe you are so young, so you never heard about that. But when I was an intern and as a resident, that usually the tutors of the surgery would talk to the CR, say that make the wound bigger, because good surgery, usually the good surgeon with big wound. So usually that's the central dogma before when I was an intern. So usually the doctor would say that make it bigger, make a big one. That's the time. That's the So, but at that time when around the 1990s, at that time I remember Professor Lee just learned from a laparoscopy from Dr. Siwadi, and I bring that back to China Memorial Hospital and said, look, just a keyhole surgery. When I was remember that because yesterday the doctor just said make it bigger, and now that Professor Lee said as a keyhole, and he put about the bipolar surgery, what we should do surgery like that as a form of keyhole. That how can we do that? That's 1990s. So that's a big change about the concept of the surgery. At that time, we learned about the pneumoperitoneum, learned about the varus needle, learned about the trocar insertion. So actually, that's totally different. At that time, I think if I know the gynecology surgery should do it this way, maybe I want to go into gynecology. When I was learning intern, you should do just always a big laboratory. So what's different is not only the wound size, but it's a move from direct to indirect. Because at that time, before in laparoscopy, you can touch it, you can feel it, but in laparoscopy, you can only see, but you have to touch the tissue through the instrument. That's totally different. Then and instead you should see the pictures from the TV, from the monitor, or not directly from your eye, just beneath your eye. You can feel it in the 3D things that you can feel it. But now you can just see things on the monitor. That's one big difference. So that's what we learned from 1990s to around 2008 or 9 or something. At that time, Professor Lee just told us, because of laparoscopy, you should put multi-port, and every port should be 8 centimeters apart, just like the size of your fist. So our resident would always make the fist to check it. Also, you should put every port 8 centimeters apart, so that that won't interfere each other. So what we have do that around 10 10 to 20 years as the conventional multi-port. So it is now called conventional laparoscopy. But then around 2008 or 2010s, a new trend that single port. So there's no more 8 centimeter things. You should put every instrument through one hole, a single incision. So where's the 8 centimeter? So what they advocate is about the cosmetic effect, the patient satisfaction, because less wound, so there's less pain, and so the first two things we had questions about really is that, but later that Chih-Feng did a study, multi-center study. Finally, they found it's controversial. So that's the conclusion. Not really, but one thing for sure is that the big one is good for the specimen removal. So maybe Professor Torng will mention about that single port surgery. But single port surgery, but in that time we have some feeling about its disadvantages. I have to mention it because the node surgery just based on the single port surgery. So there is some disadvantages because less access ports, so the less instrument allowed, and there's no things for 3 or more instrument because it's very limited space. It's only 2 instruments you can handle. And one camera, the main laparoscope with camera. So totally 3. It's so crowded, and it's also the crowding also developed from the large outer head. Not only the instrument but also the trocar. If you can notice, the trocar head is very large. Usually the crowding from the trocar head. So, and because of the crowding, so it's a limited range of motion. And one thing is that if you put everything from one single incision from one side, and you lost the triangulation. Because when we move things, the 8 centimeter, because of we need everything 8 centimeter apart, because we need the triangulation to have a good surgery. But now you put everything in one line, so it's you lost your triangulation, and also in the laparoscopy, so you have inline vision. You can imagine it, or maybe just feel it. If you see your things just beneath your nose, everything just in front of you, not from the side, only one below your nose. That actually the vision is very limited. So that's a major limitation for the limited visual field in the surgery. And when we are trying to use the conventional instrument, because now a specialized instrument was allowed what was used in the single port surgery or in the node surgery, so it's not so good to use for that, not so convenient to use of that. And one of the things is the short lens, and also because all of the disadvantage mentioned above, so it has limited ability to approach and handle it, especially difficulty in performing meticulous procedures, such as the visualizers. It could be risky in case of invasive adhesions, because in that situation you need very precise, very meticulous, or very careful procedures. And sometimes suturing that you need a lot of practice to do that. So to overcome all the crowding and interfering of each other. Because of this, usually they need longer operative time. So surely practice may overcome these difficulties, but it really has a very long learning curve. And at around, so usually there has been a consensus that if, as mentioned in the APAGE committee opinion, that if for just taking hysterectomy as example, that if you can have the choice of vaginal surgery, then the vaginal hysterectomy is usually the best choice for hysterectomy. Then if you cannot do vaginal surgery, then you can do laparoscopy, and the laparoscopic surgery and the abdominal open surgery is the least one. So since we have done laparoscopic hysterectomy, but a better choice would always be the vaginal route for vaginal hysterectomy. So this is one thing we can consider about that. So can we do that with vaginal route and vaginal surgery? If we think back about the history in the gynecology surgery, actually at the beginning in around 1970s, at that time when our teachers, they're doing 8 years tubal sterilization from the so-called Reproductive. So at that time, the patient was in prone position and that put the laparoscopy through the posterior cubotomy, and then you can find the tube and do the tubal sterilization. So it's not new. Actually, at that time, there is Reproductive. And at around 1990s, there's a new instrument called the hydrolaparoscopy from in France, and also they call it fertiloscope. They can do tubal chromatization and put a laparoscopy and fill with distension media with the normal saline, and they put a chromatization, and you can see the blue dyes that just go through from the fimbria, and as a diagnostic procedure, they call it a fertiloscopy. But it was limited for the diagnostic use. So based on this idea and based on our techniques learned from the transvaginal surgery, transvaginal single-site surgery, can we just combine it to be the transvaginal laparoscopy surgery doing for operating procedures, not only for diagnosis? So that is the original idea. So that's the way we try to do that, our transvaginal notes. And this is the first paper Professor Lee, under the guidance of Professor Lee, that our group published for the transvaginal notes during the next procedures. This published in 2012, Jamie, the APAGE journal. So we we learned that from the single site, the single port surgery, they would use the wind retractor and glove system, but put a posterior cubotomy, we put the wind retractor through the posterior cubotomy, and put the gloves on that, and then with you can see that either 5mm or 12mm trocar, and put the laparoscopy, and all the instrument doing through that as a single port surgery, but from the vagina. And we can do hysterectomy, we can do a semi-nephrectomy, we can do enucleation. And then, based on the experience, and then we can try to do hysterectomy. So this is the first paper published about the hysterectomy from transvaginal notes. The initial 16 cases published by Dr. Su Shen in Hysterectomy. So the key that so actually at the beginning of the development, we tried, Professor Lee tried to modify some different part of the procedure to doing which one is better. But you know, we are not talking about the real goal of the procedure is to do the surgery safe and do that efficiently. So we are not trying to show some difficult techniques, but we just try to find which one is the better one to make it safe and efficient. So finally, we decided, so when below the uterine artery, you can do that as conventional VTH. So just like the circumcision around the cervix and doing posterior cubotomy, and ligate and cut the uterosacral ligament, and ligate and cut the descending branches to the uterine vessels. And about the uterine vessels, we can put into the laparoscopy and do a single site laparoscopy to do the rest part of the hysterectomy. So, as you can see in the video, so now we have put the trocar, and we use two instruments in our left hand. The operator will actually in our system, the operator sit on the right side. So in our left hand, we put the big teniculum, and the left hand, in our right hand, we put the ligature. So in this case, we open the posterior cubotomy, but in the anterior cubotomy, then just leave a thin peritoneum because we're not so sure if it is bladder, but we move it and we feel the air behind the peritoneum, and then after the laparoscopy, we can open the peritoneum safely. And another tip of the operation, you can see that is you can push up the uterus into the abdominal cavity, so that look, you can push up so that you can find a large space for the handling of the laparoscopy of the nose. In this case, we remove we do the prophylactic suffixectomy and we preserve the ovary. Now we move to the right side. Similarly, push back, push up the uterus, and you can find the space. You can have good working space. And now clamp the uterine artery. So first, clamping the ascending branch of the uterine artery. So this is another advantage when you clamp the ascending branch of uterine artery. So no matter how large the uterus is, actually you have blocked the blood supply, so that actually the blood loss is not so much, even in large uterus. And you can push up the uterus so that the space is actually large enough for all the procedures. And then another thing is try to see the anatomy. Actually, it's totally different to see from above and from below. We do that abdominal approach when we are so familiar with the relationship of the anatomy. But when you're looking at from vagina and looking it up through the abdominal cavity, actually it's totally different. And you can see that's the rectum, bilateral ovary, and remove it. Actually not so small, but it's okay. And then finally to wash it and see everything, and then close it and do the procedures. So not only in our hospital that enter our publication, it's not so good experience when we are trying to submit this procedure at the first time. Even Professor Lee just tried to publish it the first time that Jamie even rejected, say, what's that? They don't know what's that. But after 1 or 2 years, and then they have a good and then finally that doctors in the US try to do the transvaginal nodes, and you can see their titles. Transvaginal nodes as a rescue. They use rescue for vaginal hysterectomy. You know that in traditionally vaginal surgery, you can feel it, but you cannot see that, especially for this next surgeries. So they say, but now with the aid of the laparoscopy, you can do the lysis of adhesion, you can see the pelvic endometriosis, you can do the erythrolysis. So even that's an extension of the vaginal surgery. So others, besides we have learned that we have this study where if we use if we have better energy resource, if we can use that with conventional bipolar surgery, bipolar electrode, or we can use the new devices. The real world experience that with new generation energy device, because they just combine the coagulation and cutting at the same time, we can do that for the complicated surgeries. So we don't need to re-explore the space by changing all the electrode and the seats or something like that. And Dr. Chen Yiren from VGH, they did the renotes too. And Professor Lee published a paper about the renotes for the endometrial cancer, and they can apply the sentinel lymph node, and also do that with myomectomy and subtotal hysterectomy. Because now time is up, so I just try to jump it up. And another some publication from the mainland China, Dr. Liu Jian, they try, and then also Dr. Walker team, they try to do that for reconstructive surgery, do that with sacropolpopexy. So it's all published. So just showing the possibility of what it's doing. But totally, as a whole, that for the transvaginal nodes, you can see that currently the concept is that it's a combination of the conventional vaginal surgery and single site laparoscopy. Just move it to the vagina to do a single site laparoscopy. So the benefit is that it's actually an expansion of the field of conventional vaginal surgery beyond where the eye can see and the fingers can feel. Especially the large uterus, it makes out the bilateral ureter, carefully enough that you can do that under the assistance of the laparoscopy. So transvaginal nodes is visible in almost the condition where the transvaginal pulpotomy is achievable. So it's one of the key points that when you can feel the pulpotomy. So but if there is a total population of cul-de-sac, that maybe is not feasible for that. And also, so on the reverse side is that since it is a vaginal surgery, so when some part of it you can do that with laparoscopy, and some part of it you can remove it out of the vagina and do that with hand. So actually, it's kind of one concept is a hand accessible procedures for vaginal root. For hysterectomy, that is the large size of the hysterectomy is visible to that because the uterus, the cervix is smaller, but if the corpus of the myoma is large, you just push it back, then it's visible to do that. But there are challenges and limitations. Challenges that it is not accessible if the pulpotomy cannot be achieved, especially for cul-de-sac population. And the possess all the shortcomings of single site laparoscopy, loss of triangulation, inline vision, instrument crowding, and so on. And just mentioned the vaginal surgery, the vaginal view and the abdominal view is totally different. Even as a gynecologist, you are not so familiar with the vaginal surgery as you imagined. So we have to remember about that. It's really totally different. So if you're interested in doing the vaginal surgery or the transvaginal laparoscopy, you have to revisit about the anatomy disorder, the orientation, and also the instrument, because there are some limitations. One of that is the anterior cul-de-sac. We cannot see that actually. Transvaginal nodes. We cannot see the anterior cul-de-sac. So one is the problem. The second is our body above the pelvic ring, the para-aortic side of that. So because the visual field is limited, that's what we need to overcome. So as a conclusion, that transvaginal nodes, you should think it as a new route of approach, a new vision of anatomy, and a new surgical method to be explored. So that we have to set up new standard, and maybe we need new instrument for the future. So, but everything is moving forward. So let's see and let's learn from each other together. Thank you.
Thank you.